Hi, everybody. It's 6 p.m. in Paris, 6 p.m. in Lille in the north of France. And it is my great pleasure to welcome you to today's ICH webinar. This is the International Academy for Clinical Hematology. I'm Mohamed Mouti from the Sorbonne University and Saint-Antoine Hospital in Paris, in France. Today's webinar is dedicated to the management of high-risk myelodysplastic syndromes, MDS. And this topic is of critical importance as high-risk MDS, as you know, remains a formidable challenge in hematology, demanding innovative approaches, but also expert insights. And we are truly honored to have with us Professor Ibrahim Yakoub-Agha from the University Hospital of Lille in France. He is a leading authority in the field, and he has extensive expertise and remarkable contributions that have influenced our understanding of high-risk MDS and its management. And I think Professor Yakoub-Agha's dedication to advancing clinical practice and research makes him an invaluable resource for our hematology community. He has occupied leadership positions at the national level as past president of the French Society of Hematology, but also within the European Society for Blood and Marrow Transplantation, EBMT, as working party chair and the current Global Committee on Practice and Harmonization. And that reflects his commitment to shaping the future of hematology and stem cell transplantation on a global scale. His vision and commitment to the field are widely recognized. So we look forward to an engaging presentation, and I do encourage you to actively participate with your questions and comments throughout this session. So thank you again for joining us today. And please join me in welcoming Professor Ibrahim Yakoub-Agha. Ibrahim, bonsoir.
Bonsoir. Thank you very much, Professor Moti. I'm fortunate enough to have this opportunity with this webinar of International Academy of Clinical Hematology. So as Professor Moti said, the topic today is the management of higher risk myelodysplastic syndrome. Where do we stand? So hello, everybody. This is my conflict of interest slide. So first of all, in front of a patient with MDS, you need to make the diagnosis of myelodysplastic syndrome. Nowadays, we have two classifications for myeloneoplasm. I'm really sorry for this because in these very difficult diseases, I would love to have just one classification, but it's okay. Now we have two. And what is new with these two classification, it's really the integration of genetic criteria alongside morphology to define MDS subgroups and AML. So the two classifications are similar, but we have some differences. For instance, when you have AML defining genetics independent of bone marrow peripheral blood blast. So as you can see here, we used to classify these into MDS now with the genetic modification, we can diagnose these patients as having AML, but there is a difference between the two classification. One, you need just the genetic modification or alteration, but for the other one, you need at least 10% of neuroblasts. And regarding the treatment or relapse criteria, because now for WHO, we have for this subcategory the diagnosis of MDS, of course, while for the other one, MDS AML. So it's a little bit difficult to navigate between these two classification. And for AML, you need to have your patient at achieving complete remission before transplantation, while for MDS, it's not necessarily. So it's a little bit difficult. However, to treat the patient, it's not the most important things. What is important is how to define high-risk MDS. So what scoring system to use? Actually, a few years ago, an international expert panel from several society recommended to use IPSS-R risk score. So just I will remind you this. So we have 5 categories, low, very low, and low, refer to lower risk MDS with median survival ranging from 5 to 10 years roughly, and 25% AML around 10 years. We have this intermediate group with the median survival at 3 years. So it's long and not long at the same time. This is a little bit in between. And of course, higher risk is high and very high MDS with median survival ranging from few months to 1.5 years. More recently, the molecular alteration become part of the scoring system. So with the development of IPSS-M, how did they do? Actually, they start with a cohort of almost 3,000 patients, and they look at the cytogenetic alteration. They observe it. 41 of patients harboring cytogenetic alteration with MDS, that's to say 60% without cytogenetic alteration, and 90% of patients had at least one gene mutations for MDS. So with all this, they could break down the patient into 6 categories: very low, low, moderate, low, moderate, high, and very high. And when we look, when it comes to the number of driver mutations, more mutations the patient present, the shorter the survival is. How to use this in daily practice, I would say. So you have this application, so you can see here, hopefully you can see my mouse. Clinical data and cytogenetic and molecular data, and you go and you will have something specific for your patient with IPSS score, IPSS-R, and leukemia-free survival, overall survival, etc. So this is something very practical and modern, I would say, because we integrate genetic alteration within. However, not all clinical feature can be classified using this. So we need more and more experience, I would say, to cover all aspects of MDS. So if we look to compare the IPSS with IPSS-R and IPSS-M, actually you can see here the higher risk patient were patient with high intermediate 2 for IPSS, very high and high, maybe intermediate for IPSS-R, and very high and high and moderate high for IPSS-M. There is some switching between the patient classified with high in IPSS and just high IPSS-R, IPSS-M. But if you look, actually, we can change the classification for a small portion of the patient if you split the patient between higher risk and lower risk MDS. So what are the objectives of therapy in MDS? Of course, we need to improve the patient quality of life. Treatment of anemia and other cytopenias when indicated, of course. Avoid first occurrence or occurrence of infection complications. Avoid occurrence of bleeding complications. And avoid iron overload and other complications that may occur because of the treatment. And of course, we need to manage risk situations such as surgery. You as a clinician or hematologist, you will have some call from surgeon or anesthesiologist saying, hi, we need to operate this patient with MDS, what we can do for the platelet, neutropenia, etc. So you need to manage this. Of course, extending survival, it's the major goal. That's to say, minimizing the risk of acute leukemia. If we target the cure, of course, you need to go for allogeneic hematopoietic cell transplantation. So I will start this presentation for the conclusion. This is my conclusion, I would say. So you have your MDS confirmed with WHO or ICC criteria. And then you need to see if your patient is with higher risk or not using IPSS-R or IPSS-M. So we recommend IPSS-M nowadays, but it's not available in every single hematology centers. IPSS-R is still a valid scoring system for those patients. And then if your patient is eligible for allogeneic transplantation, you go to transplantation. If your patient is ineligible for age, comorbidities, or whatever, so you have standard of care. What do we have as standard of care? You have hypomethylating agents and hypomethylating agent-based combinations. Of course, facing this challenging disease, so we recommend you to include your patient in clinical trials whenever possible. Of course, because really we need to move forward in this field. So now, this is 4 studies, retrospective and prospective. They compared allogeneic transplantation versus standard of care or no transplantation. As you can see here, allogeneic transplantation gave better results than standard of care. And if we look at this French study, so at the beginning, you have absolutely the same curve of survival between patients who received transplantation or not. And at 2 years, we can see here this plateau at 40% of survival. So the benefit of allogeneic transplantation became visible after 2 years, and the same result have been observed in other study also. So definitely allogeneic hematopoietic cell transplantation is still the only curative option in patients with higher risk MDS. However, the vast majority of those patients are aged more than 70, 74. That's to say, they can be candidate for allogeneic transplantation. Only a small part can be candidate for transplantation. So what to do with those patients? So for allo-ineligible patients, so we need to give standard of care. Actually, what we have hypomethylating agents. If you remember this study ASA 001 published in 2009, so it was the first study demonstrated a benefit in survival of patients with azacitidine versus conventional treatment. And based on this study, azacitidine became a standard of care and got approved, worldwide. However, since then, it has been challenging to reproduce the survival data observed in this study. either with subsequent meta-analysis as well recent randomized study, and we can estimate median survival with AZA between 13 to 19 months. So we need to keep this in mind. So with AZA, we can target between 13 to 19 months of median survival. So what to do? How to improve these results? So a lot of study have been done, hypertension-based combination, trying to pick the winner with lenalidomide, vorinostat, etc., and different mechanism of action, etc. Unfortunately, all these studies were negative. That's to say, higher risk MDS are really difficult to treat. I'll give you an example of the study. So we started really having some promising results with this phase 1b study and the combination of magrolimab with azacitidine. As you can see here, very nice response and overall survival with median non-reached, so it was something very important, and based on these encouraging, promising results, a phase 3 study was conducted, compared the combination magrolimab with AZA versus AZA placebo. Unfortunately, as you can see here, this study was discontinued because the efficacy, it's not that clear, because this is AZA with placebo, and this is the combination magrolimab and azacitidine, and toxicity profile, it wasn't in favor of these new combinations. So we have a lot of hope with the phase 2, but with the phase 3, we cannot now say that we will go with this combination for MDS. Now, another encouraging result, it's the efficacy and safety of venetoclax plus azacitidine in patients with higher risk MDS. Actually, this combination is a standard of care for AML in elderly patients, and we wanted to see if this is effective in patients with higher risk MDS. So after escalating dose, the dose for the expansion cohort was venetoclax 400 milligram, 14 days by cycle, not 28, and azacitidine standard dose, 75 milligrams squared meter, 7 days in a row. They analyzed 107 patients, as you can see here. So for the overall response, it's like 80%, but which is important for us, it's a complete remission. Because, medular or marrow complete remission doesn't mean something in clinical practice, because if you're a patient still in need of transfusion, etc., it's a good, not a good thing, but we need really a complete remission. It's 1 patient out of 3, which is very, very encouraging here. And if you look at the median survival, it's 26 months. Remember, with AZA, it's between 13 to 19, so it's ranging from 18 to 51 months. And which is important for MDS patient, it's the conversion rate. It's something like 40% of patients who were transfusion dependent became transfusion independent. And at the end, transfusion dependency was observed in almost 60% or 70% of patients, which is something very encouraging. I can tell you now, international phase 2, phase 3 study is ongoing. What about allogenic hematopoietic cell transplantation? As I said, not everybody can be a candidate for transplantation. So we need to have a cutoff for the age. So usually we use 70 years old as a good cutoff for transplantation or non-transplantation. Also, in some centers, they can go up to 75, and in some US centers, they transplanted patient aged more than 75. But 70, it's really a reasonable threshold. So first of all, you need to look at the age of the patient. Then we need to look at the comorbidities, for instance. So if we look at this optimized EBMT transplant specific risk score, it is specific for MDS, and there is another score with CIBMTR. So if we look, first of all, the age, less than 50 and more than 50 years old. Actually, for the age, we can do nothing. Blood blasts. If you have at least 1% of blast in the blood, this is 1 point. Platelet count, less than 50 gig or less than 50. Donor type, if you have identified an actual identical sibling or matched unrelated, it's a point. Cytogenetics plays a major role even after transplantation. This is something important to consider. Very good to poor or very poor or monosomal karyotype. Cytomel virus serostatus. I think nowadays it's difficult to consider this factor, but with the Litomycin and the prophylactic treatment for CMV, but at the time of this study, we hadn't this prophylaxis for cytomegalovirus. And then carnitine index, it's something very important here, as you can see here, with 1 point. So you can add all these points, and we can break down the patient between low risk, intermediate, high, and very high risk. So if we look at the survival of patients with very high risk after transplantation, so median survival is less than 1 year. So you need to consider this when you have to make a decision for transplantation for your patients. So you have the age and you have comorbidities. You can use this scoring system, or you can use the CIBMTR. It's similar to this one. Now, when to transplant? This is really a challenging question. So you remember, I would say this Markov decision model were used when we had IPSS risk score, and we could observe that patient with low and intermediate, that's to say lower risk MDS, so delaying allotransplantation was beneficial for those patients. So it wasn't necessary to start transplanting them right away. In contrast, patients with higher risk, intermediate to or high risk, allogenic upfront, it's the best option for those patients. Now, we have this IPSSR and we have this genetic mutations and alteration. So the same work has been done, including genomic-based decision. And we observe it absolutely the same results. So patients with lower risk, you need to delay transplantation for any age. Patient with higher risk transplantation, you need to transplant the patient upfront. For intermediate, maybe you can wait for patient between 40 to 55, a small number of patients, but going to transplantation become very important, in patient aged more than 61, the majority of patients, I would say. So based on this, we can say how to deal with those patients for transplantation. So you have your MDS confirmed, you have your patient fit for transplantation. So you look at IPSSR or IPSSM, as I said. For higher risk, you go right away to transplantation. For patient with IPSSR, IPSSM, lower risk, it's a dynamic assessment you need to weigh. Now, what to do with IPSS-R intermediate? So if you remember, 3 years of oral survival, we go to transplantation, we wait. So actually, you need to look at additional factors, such as myeloblasts more than 5%, profound cytopenias, hemoglobin less than 8, neutropenia, thrombocytopenia, severe bone marrow fibrosis, poor cytogenetic, and number of somatic mutation, if you remember 2 or 3 slides ago. So if you have one or more factors, so you go to transplantation. Otherwise, you continue the dynamic assessment of those patients. And a patient today with lower risk can become a patient with higher risk tomorrow if there is worsening cytopenia, increased myeloblasts, etc., and especially failure of initial treatment, especially hypomethylating agent, induction type chemotherapy, ATG, etc. So if we have this progression, so you go back, confirmation, and feasibility of allo transplant, and you continue with this. Do we need prior to transplant or bridging? This is a very challenging question. Actually, we have many retrospective studies against the prior transplant bridging. We have some conflicting results, but we don't have any prospective study. Unfortunately, we will never have such a study to compare upfront transplantation or after bridging, trying to downstaging. So how to solve this problem, how to address this question? Actually, with the chronic malignancy working party, we did this excellent study trying to answer this question. Does IPSS-R downstaging before transplantation improve the prognosis of patient with myelodysplastic neoplasm? Why downstaging? Why not complete remission, for instance? Because we know the maximum we are able to get 30% of patients achieving complete remission, not more. So what we can expect, the best, it's really downstaging IPSS-R. We never go to CR for all patients. So we split the patient between 3 categories: same IPSS-R, progressive between diagnosis and transplantation, or improving. If we look at the survival, it's absolutely the same. It's not specific. If you look at disease-free survival, progression-free survival, you have absolutely the same. So downstaging IPSS-R before transplantation, it's really not something to do, to look at, to try to have. And you need to keep in mind that with any treatment, the toxicity can be up to 30%. That's to say, up to 30% of patients will never undergo transplantation because of toxicity of bridging treatment. So this is something important. And for some patients, even after transplantation, if they develop some comorbidities just before transplantation, the result of transplantation is less favorable. And we tried to look at the patient with the same IPSS-R at diagnosis and transplantation, improving and progressive. What we can see, untreated patient with the same or hypomethylating agent have the better survival than chemo or other. This is to say failure to chemo to have the same, because you need a really complete remission with this. Improving with chemo is better, but with the other the same. And progressive disease, untreated, demonstrated a better survival. So I would like to go back saying downstaging IPSS-R before transplantation doesn't make sense. However, if you are able to organize your transplantation within 3 to 4 months after diagnosis, so go right away upfront to transplantation. Otherwise, you need to treat your patients. You cannot wait 6 months, 1 year, or 2 years before starting the transplantation. In this case, and in the case of clinical trial, so it's another things. So in this case, you need to look at the cytogenetic and marroblastos. So high risk cytogenetic, it's not good for chemotherapy and even for hypotenting agents. But if you don't have this high risk cytogenetic and you have more than 10% of blasters, so chemotherapy can be the best option rather than a hypotenting agent, azacitidine or decitabine. Otherwise, if you can organize your transplantation within 3 to 4 months, so you go upfront to allo. This is my own opinion. I know there is no international consensus on this, but unfortunately, we will never be able to conduct a prospective study for those patients. What about transplantation modalities? So first of all, it's what about conditioning? Do you need a RIC or MAC? So it's very difficult to have an idea. So we did this study, large study within the chronic magnesium working party, and trying to identify subset of patients that can benefit more with RIC and MAC, etc. And we limited this study to patient aged more than 50 years old. As you can see here, you have superimposable curve for disease-free survival or overall survival. So more than 50%, 50 years old, RIC can do exactly the same than MAC. So transplantation modality is a common sense, I would say, for donor selection. You start by matched related donor if you don't have actually a matched unrelated, and then haplo or unrelated mismatched donor, cord of blood, according to center preference, of course. For conditioning, it's really the age, comorbidities, high, you go for RIC, young, less than 50 years old, low comorbidity, maybe MAC, and the regimen, the fludarabine-based alkylam, and investigational new combination are now under investigations, such adding venetoclax and other molecules. We know patient can relapse post-transplantation, so we need to monitor them. What we can do, we have a lot of study trying to monitor those patients, but we have some problem with this because molecular genetics give insight into the pathophysiology of MDS, provide prognostic information on the natural course of disease, and help to predict the success of several therapeutic approaches, including allo. However, we still need a standardized method for MRD monitoring for MDS. I'm talking about MDS. And the optimal method for monitoring may be we need a combination of two methods to be more sure. So let me give you some studies. In this study, we did this with WT1. This is an AML. So when you have post-transplant WT1 MRD positive or negative, the difference for relapse, it's really, you don't need to look at the p-value because it's really visible. This is for the survival, you know. So when you have this WT1 high after transplantation, you have to do whatever you can to save your patient because the survival is very low. Our results were confirmed in another study, including this time AML and MDS, you know, and we have absolutely the same curve. This study, it's more interesting because they used two ways to assess the MRD. So flow cytometry, 10 color panel of 9 markers, including all cluster of differentiation. So they did this at day 30 post-transplantation, and for the genomic, they identified 39 gene. I tried to have a VAF median of 38, ranging from 5 to 50, and looking at the mutation positive or negative at day 30. So as you can see here, MRD negative, be it with the flow cytometry or mutation, plays a role, in the relapse post-transplantation. And then they mix it the two ways, the same study with negative, 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 positive, positive, negative, etc. So, but the number of patients became so small because for cohort of the patients. So I decided not to present because I think this is enough for this. So we need to confirm, to demonstrate the feasibility of such. So post-transplant intervention, what we can do after transplantation. So in this study, we looked at patients who relapsed after myelodysplastic syndrome, and the treatment received. We can see here immunotherapy gave the best result as a higher survival at 30% at 2 years. So we need an immunological effect for those patients. So what about DLI for those patients? When I say here IT, it's second allo or DLI. So what about the prophylactic? In some patient in the study with AML, actually, you can see here less relapse and better survival. But when we did the same study with MDS and AML within the French Society for Bone Transplantation, so we haven't find any differences between the cohort control or preventive. So we don't recommend really DLI prophylactic for this patient because you need to keep in mind after DLI, we observed between 10 to 15% of DLI related mortality. So this is not negligible. So you need to take into account this. For donor infusion, so when you have MRD negative and MRD positive with DLI, you have the same survival compared to MRD positive without DLI, and the same for the relapse. Preemptive way, preemptive. So you need MRD positive, for instance, to start treating with DLI. So it's very effective. And you can use DLI as preemptive based on full chimerism. As you can see here, when you are able to revert chimerism, you have better survival. And this patient received DLI, but never revert back to 100% donor. So they died. Okay, and those patients never received DLI. So preemptive DLI, it's really effective. And this is a new study unpublished yet in our centers. As we can see here, we compared the outcome of patients who received DLI with controlled disease or progressive disease. With controlled disease, as you can see here, some patient progressed despite the DLI, and other with progressive disease at the time of DLI achieved controlled disease or CR. And if we look at the overall survival, it's very easy. When you have an effective DLI, you have better survival compared to the failure of DLI. What about hypomethylating agents? So we have a lot of studies in favor of hypomethylating agent as maintenance, but it's conflicting result, mixing AML and MDS, often phase 2. And then we have this meta-analysis saying, now it's okay. This is the demonstration of effectiveness of MDS. if hypertension is in MDS. But if you look at this study in depth, you can see some caveat and issues. Mixing ML and MDS, one prospective study, DCW plus GCSF, and other one with AZA. You cannot mix these two. Some studies haven't been published yet. Only meeting abstract. You cannot use meeting abstract in the meta-analysis. And these studies were difficult to find. And there is another problem, what we call immortality time bias, because if you start the observation from the day of transplantation, of course, all patients who died before day 16, for instance, before receiving AZA, will be in the absence of AZA arm, and all the other, they could get AZA, will be in the other arm. So this is a problem, and you need to do something to avoid this immortality bias. We did the same thing at Lille University Hospital, and we compared AZA versus no AZA in those patients. And as you can see here, absolutely nothing. It's the same relapse rate. The two, based on this, we don't recommend AZA. Post-transplantation. Now, what about venetoclax plus AZA? So there are some studies, ongoing studies for this combination. However, it seems that it's a little bit toxic, and we need really to understand and to find the best dose for this combination on those patients. What about low dose decitabine plus venetoclax? This is very encouraging if you look at this study, but unfortunately, it's still phase 2, so we need the phase 3 to confirm this combination. The same thing with AZA orally. The result, it's very encouraging, but it's still phase 2, small number of patients, 20 patients, and mixing ML and MDS. So we need more studies to confirm this. So this is the whole picture. If you need to go to transplantation, you need to look at patient-related factors, MDS-related factors, transplant-related factors, and MDS transplant scores, and then you decide. My home tech message, it's hypotensive agent is still a standard of care for higher risk MDS. So far, HMA-based combination are under investigation, especially venetoclax and azacitidine. Clinical trial are very encouraged. Post-transplant relapse is still an issue for those patients. Losing a full donor chimerism can be the first marker of relapse, except for WT1. So we need something to standardize the MRD post-transplant for those patients. Prophylactic delay doesn't seem to be useful in post-transplant, and then maintenance with hypotension is no longer a standard of care. Even the European Leukemia Net does not recommend this treatment. Other drugs and combination are under investigation. So thank you very much. I will be happy to answer your question.
Thank you very much, Professor Yakoub-Agha, for an amazing, amazing and comprehensive webinar. Obviously, the glass is half full or half empty, because many of the non-transplant studies have been negative and a bit disappointing. But on the other hand, and you alluded to, we are able now to offer curability with transplant to older patients up to age 70 or even beyond. So we've received a lot of questions, so I'll try to structure them. We have a few questions, for instance, regarding drugs about the Verona study. Any insights, any information about these results?
But I can tell you, unfortunately, it's still in the list of, ineffective combination. Yeah.
Okay, so you're not very optimistic
No.
about it. Okay, one question is about the molecular IPSS. Should we use routinely molecular IPSS to decide on going to transplant or not?
So to be honest, the IPSSR, it's enough so far to distinguish between higher risk and lower risk MDS. So you can decide with this. And for intermediate, as I said, if you look at additional risk factor, so you can select the patients who can go to transplantation or not. And with these factors, I put at the end the number of driver mutations, etc. So if you can use IPSS-M, why not? But if it's not available for you to have this NGS, etc. for the patients, so IPSSR is still really a valid scoring system.
Excellent. Thank you very much. We have a lot of questions about the management before transplant. So there are questions about the threshold in terms of blasts. Is there a cutoff where you would start aza-ven, for instance? And what would be the target before stopping? How many cycles or what type of response you would like to achieve before going to transplant?
Thank you for this question. So I think with the new classification now, the majority of those patients doesn't have this much blasts. There is no cutoff. If you have an MDS, even with 13% of blasts, etc., if you are able to go to transplantation within 3 months, 4 months, go to transplantation. Otherwise, of course, if you start a treatment, so you need at least to have some efficacy. It doesn't make sense to do just one course of aza-ven and stop. You have no benefit and you have only toxicity. So if you start, at least you need 3 or 4 courses of aza-ven before referring the patient to transplantation. But whenever possible, transplantation right away, it's really the best choice. But it's not possible everywhere.
So that brings me to another question we have in those patients who are responding. So you can see that they are responding. Should we push until complete remission or even MRD negativity if we can assess it? Or should we at some point say, that's fine, I'm happy with 4% of blast and I'll go to transplant?
The second option, Professor
Okay,
Motti.
so
No,
we should not push too much to
no,
achieve CR or MRD
no,
negativity.
no, because first of all, we don't know what does it mean this. We don't have data for this. And secondly, as you know, those patients, they can be controlled. And then one day you have this relapse and you lose everything.
We have another question from Dr. Murad Ali about actually the two hypomethylating agents, namely 5-azacitidine and the citabine. Are they equal? Can one overcome the resistance to another, or for you, it's just use whatever you have?
Absolutely. Just use whatever you have. In some situation, it was reported that decitabine can, overcome azacitidine, etc. But I'm not sure that you have the two drugs in the same country. So the easy question is use whatever you.
Excellent. Thank you very much. We have another question. In one of your slides, you have mentioned cord blood as a graft source option. And we have a comment here that allo in MDS, there is a big risk of non-engraftment. So what would be your optimal approach, strategy, and maybe conditioning to ensure engraftment and avoid graft rejection, whether primary graft failure or secondary rejection?
Yeah, I do disagree a little bit that MDS, it's not really a disease we face, graft rejection that easily, or, it's not like myelofibrosis. The engraftment rate, it's very correct with after MDS, I would say. Now, for cord blood, actually, I don't use cord blood anymore, but I still have some pediatric colleagues. They have patient aged at 5 years, 10 years, etc. They develop, it's very rare, but they develop mild dysplastic syndrome, and sometimes they continue using cord blood, if this was the question. But for me, for adult, no. It's really easy. We start, as I said, HLA matched, related, unrelated, and then mismatch, or haplo, we don't know. So you can choose.
Excellent. Thank you very much. One question about DLI. So you concluded that prophylactic DLI is not of a great value. What about curative DLI in case of progression after transplant?
It's very important, I think, and especially if you can combine, chemo, for instance, or Vidaza, venetoclax, then DLI. This combination, it's really effective. As I demonstrate the slide, the study we did, we had some patients, with progressive disease achieved complete remission after DLI, especially with this combination.
Excellent. Another question about maintenance therapy after transplant for MDS. If the patient wasn't actually responding to azacitidine, would you still use it for maintenance after transplant?
If the patient responded or not, I don't use azacitidine after transplantation.
Okay.
As I
Well,
showed
the next
you,
question we have is, what is your choice for maintenance therapy?
unfortunately, nothing. Monitoring the patients and DLI, preemptive DLI, and tapering immunosuppressive treatment for those patients, So close monitoring and DLI when needed.
Well, superb. I think we can spend the whole evening or afternoon on this very exciting topic. I'd like to take a moment to express our sincere gratitude to you, Professor Yakoub-Agha,
Thank you very
for
much.
sharing your expertise on the management of high-risk MDS. I think the very thoughtful, comprehensive analysis you've done during this webinar has truly enriched our understanding of this challenging area. And again, I'd like to acknowledge Professor Yakoub-Agha's contribution, not only as a clinician and a researcher in this very difficult field and hard to treat field of MDS, MPN, but also as a leader who has occupied key positions within the different transplant societies, especially EBMT. I think his commitment to our field is evident, and we look forward to seeing the positive impact of his continued leadership. I'd like to thank you all for your active participation and the thought-provoking questions. There are actually more questions than answers in this domain, but I think this live engagement with the audience is part of the ICH DNA, and it is essential to fostering the exchange of ideas and driving progress in hematology. So this is the International Academy for Clinical Hematology around the globe and across the hematology field. Wherever you are, please stay safe and keep well. Take care. Thank you.
Thank you very much.